Welcome to Clinical Medicine 2. In this presentation, we will discuss hip osteoarthritis. Before we begin, I would like to take a moment and acknowledge and thank Dr. Greg Ford, as he was instrumental in the development of this presentation. By the end of this presentation, the learner should be able to describe the etiology and prevalence of osteoarthritis, describe how hip osteoarthritis is diagnosed both clinically and radiologically, and describe the evidence-based physical therapy intervention for individuals with hip osteoarthritis. For the cervical spine, we presented a treatment-based classification scheme to help guide your management of those patients. We're going to do the same for the hip. We're going to do the same for the lumbar spine. For the hip treatment-based classification scheme, this is from Rob Roy Martin and his colleagues, and you have those two papers, and I would recommend reading those papers very, very closely, because in there you'll see these different categories and the importance of them. So when we evaluate a patient who has primary hip pathology, we're going to determine, are they predominantly a patient who has to get mobility back, or if they have adequate mobility, do we need to get strength back? And then let's look up a little more proximally to the trunk and determine, are we dealing with core trunk muscle weakness or lumbar hypomobility issues as well. And those last two categories on the right are important, and the papers talk in detail about how we're going to address the lumbar spine, and we'll do more of that in this course as well. But for now, our main goal is to determine where are we at with respect to mobility and with respect to lower extremity strength and motor control. And so with respect to mobility, we're looking at range of motion again. We're looking at flexibility of hip musculature with the test that we previously described, as well as joint capsule accessory mobility assessment. Older age and abnormal anatomy, that relates back to whether or not we're dealing with potentially hip osteoarthritis. With respect to abnormal anatomy, we could potentially see a labral tear that could be influencing joint mobility, and in some cases that has to be repaired surgically. But the key there would be to begin to mobilize the joint and ensure that the individual has the appropriate stretching exercises provided. And then if we're dealing with lower extremity weakness, we pick that up through our manual muscle testing and our functional assessment. We're going to want to make sure we provide the appropriate strengthening exercises for these individuals. And so read the papers, and we'll talk more about this as we progress through the intervention component of the lecture. We've described this study in detail previously, but again, this study reviewed the leading causes of disability in terms of disease. And as you can see toward the left there, back and neck pain, as well as depression, are right up there near the top. What I've circled, again, is just to show you the influence of osteoarthritis with respect to disability. And it's going to be a condition that we're going to likely see in individuals over 50, and the hip and knee seem to be affected most. And so these are patients that you're likely going to see a fair amount of in the clinic. And for these individuals, it's important to have a plan as to how we can manage these folks in an evidence-based fashion. As you saw in the last slide, we begin to see osteoarthritis beginning to really become a problem in individuals over 50. And then if we start to look at the data, really by age 60, it really becomes quite common for folks 60 and over to have complaints related to osteoarthritis. It's important to also note that osteoarthritis may also be referred to as degenerative joint disease or DJD. And again, you'll see that in the literature. You'll also see it in patient medical records as well. When we look at the influence of osteoarthritis on our patients, it really is several different aspects of their lives that are influenced. We certainly see difficulty with their activities of daily living and recreational activities, and we also commonly see challenges with individuals who have osteoarthritis being able to work at the level that they would like. One of the main concerns for some of our patients who are a little bit older becomes their level of independence, and how is that going to be affected by osteoarthritis. And so we've spoken about this before, but I think one of the most important things that we have to do as physical therapists is determine where our patients are at in terms of their ADLs, in terms of their occupation, in terms of their recreational activities, and their levels of independence. Where are they at currently, and where would they like to be? And then it's our job to really try and determine what is the likelihood of them achieving those particular activities at the level that they would like, and the time frame for that. And so when we're dealing with individuals who have osteoarthritis, these are going to be some of the main areas that we're going to see affected, and these are the areas that we're really going to work to try and return patients to with our management strategies. In terms of the etiology of osteoarthritis, it's really multifactorial. We're certainly going to see mechanical factors involved, and that really relates to the amount of stress that's placed on joints and how well our articular cartilage can respond to that mechanical stress. Metabolic factors are also going to be a factor. Remember, metabolic factors really relate to these biochemical processes that really allow our body to function normally. And you say, well, what are some of those? Well, we would think about these biochemical processes that could potentially adversely influence some of our internal organs, like the heart, the lungs, the kidneys, and the liver. And so we would begin to think about conditions like obesity, hypertension, hyperlipidemia, and hyperglycemia. These factors will not only adversely influence the functioning of some of our very important internal organs, but it'll also influence the functioning of our bone and articular cartilage as well. And then finally, genetic factors really relate to how well the articular cartilage has developed, and then how well the articular cartilage can respond to stress over time. Because remember, this is really, this whole concept of osteoarthritis is really this dynamic process that is really characterized by an imbalance of tissue repair and breakdown of these synovial structures. And ultimately, what we see in folks is really chronic pain, joint deformity, and loss of mobility and function. And as physical therapists, hopefully we can intervene, right, and improve mobility and function in these patients. And so the remainder of this presentation, we're going to spend talking about hip osteoarthritis. We're going to present to you how we diagnose hip osteoarthritis, not only clinically, but radiologically, and the importance of physical therapists looking at, right, some of these medical special tests that have been done, like radiography, and how is that going to inform your management of a patient who has hip osteoarthritis. And then we will talk about how hip osteoarthritis is really managed from an evidence-based perspective. On the last slide, I mentioned that it's important to investigate the special tests that your patients have had done. One special test that's important, especially for patients who are at risk for metabolic bone disease and decreased bone density, would be a DEXA scan, or a dual X-ray absorptiometry test. And a DEXA scan is kind of neat because it sends two different types of X-rays through the hip. That's where that dual comes from. And it determines how much of that X-ray beam actually passes through the hip. In a healthy hip with normal bone density, most of that X-ray beam would be absorbed. However, if you're dealing with a hip with decreased bone density that's a bit less dense, that X-ray beam is going to be able to be pass right through and get picked up on the other side by the detector. And so we can determine how much bone density there is by looking at where does that individual fit with respect to the normal population. And so on the left, you can see, left top, you can see how that X-ray looks and then you can see some of the computer graphics associated with it. And then on the right, you can see that anywhere between 1 and 2.5 standard deviations, which we call a T-score, the individual is considered to have osteopenia, and anything more than 2.5 standard deviations below normal, the individual is considered to have osteoporosis. And so once again, we're looking to determine how much bone density does the individual have compared to a normal population. And individuals who have osteoporosis and even high-grade osteopenia are at risk for a fracture. And so what are some of the risk factors that we see as contributing to osteoporosis? Women who are over 65 years of age and who weigh less than 140 pounds at menopause. And part of the concern with menopause is that after menopause we see less of the female hormones, estrogen and progesterone, and those play a key role with bone mineral density. Corticosteroid usage as well is another factor that could potentially influence bone density. So if we see women who are older, whose body habitus is a little less or a little more slight, these are individuals who are going to be at higher risk for osteoporosis. And the DEXA scan is important again because it gives us some understanding of the amount of bone density that the patient has. And so if a patient is dealing with higher grades of osteopenia or osteoporosis, we want to make sure the appropriate interventions are put in place to help increase that individual's bone density and lessen their risk for a fracture down the road. Another common medical test that you'll see done with individuals who have hip pain are going to be hip radiographs or x-rays. And hip radiographs are really good at picking up osteoarthritis, especially in the more advanced stages. And it's important that you know the classic findings of osteoarthritis that we see on radiographs, which are asymmetrical joint space narrowing, osteophyte formation, subchondral cysts, and subchondral sclerosis. These are important, as we'll talk about in a minute. The more of these that we see really helps us understand how advanced the pathology really is. Let's kind of go through these real quick. So with respect to the joint space, the image on your right, I drew a red arrow there, and I want you to appreciate the joint space between the femoral head and the acetabulum. And that joint space should be symmetric, meaning it should be equal all the way through. And if you look at that particular joint space at the top and at the bottom, we see decreases in the amount of joint space there. And if you look more medial to the femoral head, you see that joint space kind of open up a little bit. Asymmetrical joint space narrowing is a classic finding for osteoarthritis. If we're dealing with symmetric joint space narrowing, that's more consistent with inflammatory arthritis or something like rheumatoid arthritis. And so keep that in the back of your mind as you're studying these images. Osteophyte formation, we see these as extra bone spurs, if you will, sometimes we call them, and all they really are just a response to that wear and tear where bone begins to build up, and we sometimes see it at the bottom or the top of the joint there. And so if you look on the image on the right where it says bony spurs, that's an example of an osteophyte formation. Subchondral cysts are kind of interesting. On the left, you can see where I drew those tiny black arrows. You can see these little circles, these little dark circles, which are areas of decreased bone density, areas of lucency, where articular cartilage is kind of worn down, and we begin to see pockets of synovial fluid forming in there. So you'll see these dark circles. Those are subchondral cysts that form. And then subchondral sclerosis, if you look at the image on the left where those black arrows are, you can see how the bone around those black arrows is really, really white. What that means is that there's increased bone density in that area. Why? Because the joint space is now gone, the articular cartilage is now gone, so now we have bone on bone. And that bone on bone causes increased bone density over time. So we see that sclerosis there. So once again, the 4 findings: asymmetric joint space narrowing, osteophyte formation, subchondral cysts, and subchondral sclerosis, all key findings in diagnosing osteoarthritis. The Kellgren and Lawrence radiographic grading scale is typically used by radiologists and researchers to classify individuals according to the amount of radiographic change that they have. So for example, grade 1 would be very, very minimal or doubtful narrowing of the joint space, and there may be some subtle osteophyte formation. And then as we move up through grade 2, grade 3, and grade 4, we see more and more of these changes taking place with respect to more osteophyte formation, more and more decreased, more and more joint space narrowing, and we may see more sclerosis as well associated with this. And the bottom line with this scale is that the higher up in the grade that we are, the poorer the prognosis is going to be for conservative treatment. And typically we see individuals at grade 3s and 4s moving on to total hip arthroplasty. Folks at grade 1, grade 2, and even potentially grade 3 can respond quite well to our interventions. And so it's an important scale that you should know about. You'll see it used clinically as well as for research to classify patients in treatment outcome studies. As I mentioned in the last slide, the baseline grade that an individual has in their radiographic findings for the Kellgren-Lawrence radiographic grade is going to be important as a predictive factor for folks who are going to have to move on to operative management, THA, or total hip arthroplasty. And if we look at, once again, grade 2 or greater, it's a strong predictor that the hip OA is likely going to progress, especially in individuals a little bit younger. But as we look at grade 3 and grade 4 especially, the odds of an individual having a total hip arthroplasty go up significantly, especially with a grade 4. And so again, the Kellgren-Lawrence radiographic grades are important. They can help us establish prognosis, and they can also help us establish some understanding of who's going to do well with conservative therapy and those that might require operative management in the form of total hip arthroplasty. On the last slides, we described the radiographic criteria that are used to diagnose hip osteoarthritis. This slide looks at the clinical criteria used to diagnose osteoarthritis of the hip from the American College of Rheumatology. And if you look at this decision tree, we start with pain in the hip, and then at this particular point, we can go to the left or to the right, and really what we look at are range of motion findings. And so on the left, you see that hip internal rotation less than 15 degrees and hip flexion less than 115 degrees or a normal SED rate. The ESR there is an erythrocyte sedimentation rate less than 45, which means that generally there's no systemic inflammation occurring in the body. And so this is from a rheumatologic group, and so if that SED rate was elevated, there would likely be concern over some type of inflammatory arthropathy like rheumatoid. However, since osteoarthritis is not considered inflammatory, a lower SED rate fits that criteria. So on the left there again, if you're dealing with someone who has limited hip internal rotation less than 15 degrees and limited hip flexion of less than 115 degrees, you're pretty much good with knowing that this individual likely has hip OA. Also, if they have a SED rate that's normal, or in this case less than 45, that is a laboratory test that's used again to determine whether or not there's systemic inflammation in the body. Or you can go on the right side. If you don't have access to lab testing, we look at, once again, hip internal rotation less than 15 degrees. There's pain associated with that measure. We have morning stiffness less than an hour. Again, since osteoarthritis is non-inflammatory, we may get folks who wake up, they feel stiff in the morning, but it's gone by 30 or 45 minutes if it's OA. If it's rheumatoid, however, they'll be stiff well beyond that hour because that's an inflammatory disorder. And then age is in there as well. We spoke about that before. And so be familiar with these criteria. I think they're important because you could get radiographic findings, especially those grade 1 or grade 2 Kellgren and Lawrence scales. And we want to determine, is that clinically significant? And this particular criteria helps us do that. On the last slide, we described the ACR criteria for the clinical diagnosis of hip osteoarthritis. On this slide, this is another series of criteria that you may see reported in the literature as well. These are Altman's criteria for hip osteoarthritis. It's really from the same group that had come up with the ACR criteria, and as you see on the left there, the clinical criteria are very similar to what we've described previously in terms of loss of range of motion, specifically in terms of hip internal rotation being less than 15 degrees and hip flexion being less than 115 degrees. Morning stiffness, if it's present, it shouldn't really last for longer than an hour. Pain with hip internal rotation, range of motion, and then of course an age component as well. And we've talked a bit about that already. When we begin to see folks over 50, we see the prevalence of osteoarthritis certainly increase. When they do these studies, they're looking at these reference standards of some of these classic findings on radiography that are associated with hip osteoarthritis. And if you look off to the far right there, you can see the sensitivity and specificity of this model as being quite high. And remember, when we talk about sensitivity and specificity, we're kind of dichotomizing those outcomes. We're saying, is this model sensitive or not? Is this model specific or not? And I think that, and there's different ways of looking at this, but I think that, when we look to determine if something is sensitive or specific, I think numbers around 75 and 80% and above probably tell us that it is likely sensitive or specific. We can say that with some confidence. And so in these cases here, this model is sensitive and it is specific. So what does that mean? With respect to sensitivity, if individuals don't have these findings, right, they don't have limited hip internal rotation or limited flexion, they don't have pain with internal rotation, they don't have morning stiffness, and they're younger, right? I think that if you have that cluster there that we just described, we would probably say that this is not related to hip osteoarthritis. However, the specificity suggests that if they have these findings, and I'd say that you probably need at least four of these. I'd say you probably need age, you probably need one of the range of motion components and pain associated with that, and you probably need to have that consideration of a lack of morning stiffness. So you probably need at least four of these. That's specific, meaning that even if you don't have radiographs and a patient has these findings, it's likely that hip osteoarthritis is present, and I would recommend that you focus your management strategy in that direction. So again, very, very powerful clinical criteria, because as physical therapists, we can't order diagnostic imaging in the vast majority of settings we're going to practice in. So these criteria help us proceed with some confidence that this important clinical diagnosis is present, even if we don't have radiography. Now, maybe our patients will have radiography, and we should be always thinking about those findings that we talked about in terms of things like joint space narrowing, especially if that joint space narrowing is asymmetric, osteophyte formation, sclerosis, and subchondral cyst formation. And so the radiograph we have here, this is a patient that I had seen previously. He was a 55-year-old gentleman who had a complaint of left-sided hip pain. He brought these radiographs in with him, and so we were able to look those up on the computer for him and take a look at his left hip. This is a standing AP. Just a routine AP radiograph of the pelvis, and on the left side, which is on your right, you can see that his hip does have some of these changes associated with it. I'd say take a moment and look at this radiograph and see if you can find the joint space narrowing. See if you can find subchondral cyst formation. See if you can find presence of osteophyte or bony overgrowth, and see if you can find subchondral sclerosis. So go ahead and study that image and see if you can pick up on some of those findings. Now that we've taken some time to describe how hip osteoarthritis is diagnosed both clinically and radiologically, I think it's important for us now to turn and look at the evidence-based management of patients who have hip osteoarthritis. So the next several slides will describe some of the clinical practice guidelines associated with the management of patients with hip osteoarthritis, and then we'll present a study to you that looks at the effects of manual therapy, therapeutic exercise, and patient education in individuals who have hip osteoarthritis. And so for the clinical practice guidelines for hip osteoarthritis, these were published in 2017. It was actually a revision from a document that was put together several years prior. And as you can imagine, as the evidence continues to be updated and changes, you're going to need these revision documents. So we'll present this one to you. And when we talk about these clinical practice guidelines, always the first couple of pages has a nice summary of the guidelines. We're going to post these for you, and I want to make sure that you have a good handle on the summary of the guidelines, and certainly you can delve in deeper to the guidelines themselves to get more information as necessary. Before we present the guidelines, it's important that we have a brief discussion as to how the evidence is going to be graded. And so we're going to see grades from A through F. When we begin to see evidence along the lines of grading as A and B, those are procedures and techniques that we're going to want to be sure that we include in our management plan. With respect to grading of a C, where we see weak evidence, I think the key there is to look at what the risk-benefit analysis is for these, and you know, we'll talk about some of the evidence that's graded as a C, but it's very, very low risk. For example, weight loss is graded as a C with individuals with hip osteoarthritis. There's very low risk, right, to educating individuals on the benefits of weight loss and potentially getting them to see a dietitian or a nutritionist to assist with that process. In fact, it likely is going to be very, very beneficial for their overall health if they would be able to lose weight. The weak evidence comes from the fact that if individuals do lose weight, how much does that actually help their condition necessarily with respect to the hip? And so we'll talk about this a bit more as we go through the guidelines. As I mentioned, take a moment to review the summary recommendations for the guidelines, and with respect to this particular page here, take a moment and review the diagnosis and classification section, the examination with respect to outcome measures, the examination with respect to activity limitations and physical performance measures, as well as examination of physical impairments. And so those are going to be, those are components that we spoke about previously with respect to our history and physical exam, but it's worth the time to take a look at those and see that those are ranked very, very high. And so we want to use outcome measures. We want to use measures of physical performance. We want to ensure that we evaluate range of motion and strength in a very, very reliable and valid manner, because those are key factors that are going to drive our management. And with respect to management, you can see there that patient education is going to be important. And with respect to education, we're certainly going to discuss the pathoanatomy and the disorder with individuals so they have a better handle on that. But we're going to speak to them about what activities that they may need to modify. We're going to speak to them about the possibility of using an assistive device to offload these particular joints. And we're going to speak to the rehabilitation plan and why that's important and how that really plays into their prognosis. With respect to manual therapy, you see there in the bottom right-hand corner, it's graded as an A. So manual therapy is something we're going to want to employ and utilize with our patients. Again, these are patients that are going to fit in that hypomobility category of our treatment-based classification scheme, so we're going to want to address that. We're also going to want to use flexibility and strengthening exercises to supplement our manual therapy as well. You see there that Just above the manual therapy area, you see that functional gait and balance training receives a C. And so I would say that certainly when we think about risk benefit, when we think about balance and functional training, ensure that what you employ with the patient is safe. But we've already talked about using things like the TUG, timed up and go test. And if patients are below those cut scores that make them high fall risks, we have to employ that. And if we're talking about gait training, I think that if we're dealing with individuals who have an antalgic gait, there's pain associated with gait that's influencing their function, consider an assistive device to offload that, and make sure the patient's educated on how to use those. As we work with our patients with respect to manual therapy and working to improve joint mobility, remember that flexibility, strengthening, and endurance exercises are also going to be important as we continue to progress the patient through rehabilitation. Those activities receive a grade of an A. So those are activities that we're going to want to include. With respect to modalities, bottom left-hand corner of this particular slide, you can see that modalities receives a B. That's specifically for ultrasound. Ultrasound at specified settings over periods of time can, in fact, improve pain. And once pain's improved, we see improvements in function. So consider ultrasound in the management of these folks. And then the bottom right-hand corner there is weight loss. Again, it receives a grade of a C, but the risk benefit of this really weighs toward the benefit. And so although nutritional guidance and diet is now part of a PT's Practice Act, I think that it's important to involve dietitians and nutritionists who have expertise in this and working with patients. And it's an activity that you want to consider with your patients, because even losing 5 or 10 pounds, taking that pressure off of a joint, will make a big deal. As we've presented those clinical practice guidelines, you can see that these patients are likely going to fit in that hip hypomobility category. We're going to want to use manual therapy to address that. And then with respect to lower extremity weakness, hip and lower extremity weakness, we're going to want to use strengthening exercises to address that. And so these patients with hip osteoarthritis are definitely going to fit in these two categories quite nicely. And these are really going to be the bulk of our rehabilitation efforts. In the guidelines, strength and endurance exercises were also included. And it's important to know that with respect to strengthening, we're talking about anywhere between 3 to 5 sets of 6 to 12 reps. Now, with respect to strengthening, you have to get to the point where when you're at rep 10, 11, and 12, you're really pretty much to fatigue. It's hard to sometimes do that when we're dealing with musculoskeletal issues, because the tissue can't necessarily take the force necessary to get to that point when you're doing strength training. And so early in rehab, when the tissues, especially it's still healing and it's still sensitive to stress, it's not a bad idea to use endurance type activities. And so we can load the tissue while it's healing with 3 to 5 sets, 20 to 30 repetitions with an appropriate weight. And then when you think about rep 25 to 30, there should be some effort to complete those last few reps there. And then as the patient progresses with respect to rehabilitation and the tissue becomes less sensitive to stress, now we can begin to employ more strengthening activities where we have more weight, more load onto the tissue, and the patient can now tolerate that. With respect to the other end of this, when we think about articular cartilage, we look at, thousands and hours of repetition and say, well, how would we do that? And again, that's where these endurance activities come in, because endurance can be with respect to weight training, but it can also be with respect to walking or cycling. And these are activities we're going to want to employ with our patients. And so having patients utilize stationary cycling, treadmills, community walking, etc., that's really going to help the articular cartilage in these folks, because that's going to really lead you into that level where we want to get, where we start thinking about really lots and lots of repetition and significant amount of time spent on that. We've spoken about the guidelines for rehabilitation for patients with hip osteoarthritis in a general sense. We've talked about making sure that we appropriately address their gait, we appropriately address the hypomobility associated with the hip in terms of our treatment-based classification scheme with respect to manual therapy and some flexibility exercises, and then appropriately addressing muscle strength as well as endurance capabilities. And you may say, well, that's all great, but how do I approach it? What exercises do I do? What manual therapy techniques do I do? While clinical practice guidelines are great, they don't get down to that level of detail. Rather, they tell you from a 30,000-foot view what works. Manual therapy works, okay? Well, what techniques do I do? Flexibility exercises work. Well, what techniques do I do? And to get into that level of detail from an evidence-based perspective, I think you have to look at case series or even case studies that provide that type of information for you, where you actually have that level of detail. And so in this particular case series, this is a group of individuals. These are a group of military PTs who are doing a manual therapy fellowship through the Army, and they decided to look at an approach with respect to manual therapy and exercise for patients who have hip osteoarthritis. And they took 15 consecutive patients, mean age of 52 years, with unilateral hip OA, and they took them through a program of over 8 weeks of 10 visits, and each visit was about 30 minutes. And let's go ahead and talk through this trial, okay, and help you understand some of the subtle nuances of it and some of the outcomes associated with it. I want you to note that this is posted on the Blackboard site under the Lecture 2. It's under Research Study, and I would definitely take a look at it because I think there's lots of really good information in there to help you manage patients with hip OA. As we've mentioned previously, there's 2 different ways of diagnosing hip OA. One is through radiographic criteria, radiographic findings such as decreased joint space, sclerosis, osteophyte formation, and subchondral cysts. That's one. The other way is to use the American College of Rheumatology's classification for hip osteoarthritis. And there are a couple of different ways of doing that. In this particular study, they used some of these Altman criteria and looked at 2 test clusters, and this is how they defined their patients with hip osteoarthritis. So test cluster 1 was that they had to have pain reported in the hip, and they had to have flexion less than 115 and internal rotation less than 15 degrees. So you should be familiar with that. Or test item cluster 2, which is pain with internal rotation of the hip, less than 60 minutes of morning stiffness, and greater than 50 years of age. So if they had all 3 findings from either test cluster, they were included in the trial. It's important that you know this, because who are these patients that they're treating in this study, right? These are patients with hip osteoarthritis based upon the clinical criteria from the American College of Rheumatology. Did all of them have x-rays? I'm not exactly sure if they did or not, but if we started to x-ray these folks, it's likely they're going to have, stage 2, maybe stage 3 on the Kelvin and Lawrence scale, right? And so these are patients who had hip osteoarthritis based upon the clinical criteria, which you should be familiar with at this point. And so in this particular study, once the patients were diagnosed, they were invited to participate. They had 15 individuals who said they would participate. They evaluated them with respect to range of motion findings, a numeric pain rating scale, as well as the Harris hip score. So we'll talk about those findings in a second, but they did all that, and then they went ahead and treated these patients 10 times over the course of an 8-week period, and then they reassessed. They also then reassessed at a mean of 29 weeks as well. And so the manual therapy and exercise were delivered during these 10 30-minute sessions. And why is that important to know that? Because a 30-minute session, most physical therapists should be able to do that, right? If you're in a clinic where you have to manage 4 or 5 patients at a time, this protocol isn't going to work for you. But I would say get yourself set up in a clinic where you can get a solid 30 minutes with your patient, because during that time you're going to do a fair amount of manual therapy, you're going to instruct in some exercise, and you're going to educate. But those one-on-one visits are extremely important, and 30 minutes is not too much to ask for that particular session. So in my mind, pictures are worth 1,000 words. And when we start looking at, well, what manual therapy was done, there are two techniques on the right-hand side. The first two boxes on the right-hand side, they did hip flexion with the caudal glide. We'll talk more about that next time. They did internal rotation with distraction. We'll talk more about that next time as well. And if you notice, both of them were using mobilization belts for those. If you go down, the third box in both the left and right column shows you a long axis distraction technique, and that's another mobilization technique. And then finally, the patient is positioned prone into this flexed abduct, externally rotated position, and the therapist is doing posterior to anterior pressures there. And so they're doing a mix of grade 3s and grade 4s with these particular procedures. These are not patients who are pain dominant at this point. These are patients likely with chronic osteoarthritis. These are individuals who they can mobilize with grade 3s and grade 4s, 3 sets, 2 to 3 minutes each. Okay. The stretching exercise that they did are in the top left-hand column there, an iliopsoas stretch, which is very similar to the Thomas test position, and then a piriformis stretch. And why are they doing this group of exercises and this group of stretches, this group of mobilizations? Because these are the techniques that have been shown to address the joint mobility deficits in these particular patients. We're looking to improve flexion. We're looking to improve internal rotation. And so if you look at these flexion internal rotation postures with respect to our mobilizations, upper two boxes on the right, we're using a mobilization belt to assist with that. Long axis traction, like you guys have learned, traction pretty much assists with just about everything. And then this prone posterior to anterior stretch or mobilization technique, while they're in that Faber position and prone, really works well to improve hip extension. And then finally, iliopsoas stretch, that's going to improve hip extension. And piriformis stretch as well, it's going to allow that hip to rotate much better. And so all those are going to be important, and these are the techniques that were primarily used. In the paper as well, they provided a table that has the rationale for their manual therapy intervention selections. And I would take a moment and look at the rationale for each technique that they used. So for the stretches, what were they trying to do? And with each of their mobilization techniques, what were they trying to do? The goals here are really to improve rotation, improve flexion, and improve extension of the hip. And each of these techniques are good at doing that. And so the clinical practice guidelines also spoke about utilizing strength, endurance, and flexibility exercises with patients in addition to manual therapy. It's important to note that these patients were also educated with respect to regular cardiovascular exercise. We spoke about the benefits of that already, things like stationary cycling and biking. Those are going to be important. And then the potential benefits of weight reduction and weight loss. So they were spoken to about that, and it was a continuing theme to see how patients are doing with that and to make sure that they're progressing with that regard. With respect to exercise, though, let's talk about flexibility. We already know that some manual techniques were being done to improve length of the hip flexors as well as the piriformis muscle. And so in this particular trial, they were given knees to chest, a hip flexor stretch, as well as a piriformis stretch to do at home. They also were given some strengthening exercises for the hip abductors and hip extensors. So for the hip abductors, they were doing side-lying hip abduction as well as a clamshell exercise. And then they were doing a bridging exercise, a single leg or a double leg bridge, whatever they can do. And the patients were progressed from this point, right? So this was a home exercise that they were doing. They were doing this pretty much every day. And the patients were asked to keep track of that, and then when they came back in, the therapist reviewed the exercise program with them to make sure that they were compliant and performing the exercises correctly. But the bottom line here is, from an evidence-based perspective, we want to maximize flexibility of certain muscles, we want to improve strength and flexibility, we want to improve endurance of certain muscles as well, we want to make sure that patients are staying active and looking at weight loss options as well. That's all in the clinical practice guidelines. So all this study did is take the clinical practice guidelines and just implement it with 15 patients, and let's see what the outcomes show. Prior to this study, we mentioned that individuals were evaluated with the Harris Hip Score. They were also evaluated numeric pain rating scale, and hip flexion and hip internal rotation were both evaluated. On the left, we can see Harris hip scores and numeric pain rating scale scores on a scale of 0 to 10, all annotated for us. And you can look at the Harris hip score, which is the blue line. They started around 60, which is generally a poor level of function. And they bumped up to around an 80, which is a very, very good level of function for this particular group. That's a great change in function, great improvement in function. And it looks like it stayed there over the course of 29 weeks. The patient started at maybe between a 4 and a 5 with respect to numeric pain rating scale. Remember, this is current, best, worst on a scale of 0 to 10. We take the mean, we go from there, and they drop down to, it looks like, around a 2. So they had at least a 2-point change. That bumped a little bit up over the course of 29 weeks, though. And then if you look over at range of motion, both hip flexion and hip internal rotation both improved. Based upon these numbers, it looks like hip flexion was probably affected a little bit more at baseline, but both of these continued to improve, and that is going to definitely help with respect to function. And so for this particular study, I think it's important to see how those clinical practice guidelines were implemented with this particular patient group. If you're dealing with patients with hip OA, I would not recreate the wheel. Right? I would go ahead, go through your evaluation, but at a minimum, include the techniques in this particular study. And if there's any other impairments that are glaring to you, deal with those as well. Okay, but make sure you use something like a Harris hip score or WOMAC and a numeric pain rating scale, and track range of motion really, really well. The other thing I want to mention is that if you look at the Harris hip scale score and you look at the NPRS, you notice that between 8 and 29 weeks, those individuals continue their home program, but you can see that those scores start to go down a little bit, meaning that the number score, the numeric pain rating scale score actually goes up, meaning they have a little bit of increased pain. And you look at that trend for the Harris hip scale score, it's starting to go down a little bit, meaning that function is starting to decline. We'd expect that. And so I would think that just like you see a dentist every 6 months, get these patients back in every 3 and 6 months for a tune-up visit or two. Because if you can tweak those impairments and continue to boost their exercises, look at their endurance activities, make sure you keep tweaking their improvements, you can definitely keep these patients on the straight and narrow. But you have to see them probably every 3 to 6 months for just a visit or two. But at the end of the day, this cluster of visits up front definitely improved function, improved pain, improved range of motion, and most of those were maintained. However, a booster visit or a tune-up visit down the road would definitely help that as well. So hopefully this is going to assist with your management of patients who have total hip arthroplasty. So in this presentation, we've discussed hip osteoarthritis in terms of diagnosing it, both clinically and radiologically. And we've also described the evidence-based management of it. In our next presentation, we'll describe what really is the next step in management of patients with hip osteoarthritis, and that will be total hip arthroplasty. Please let me know if you have any questions or concerns with the content. We hope that you enjoyed this presentation. Thank you.